I do miss them, like, all the time, you know, and see everybody just walking the bridge, you know. I was like, yeah. I know. I will. I need to watch That's great.
I just want to let everybody know this is being broadcast, I guess, to the outside hospitals. We're still waiting for our guest speaker to arrive. They did send pre and post-test for this discussion, so Joey will be handing out the pre-test shortly for everyone to take and register in. So in the meantime, enjoy breakfast and we'll just wait for you to arrive.
Sorry. Hey, Greg.
Yeah, so if you need anything, I'll carry it over to you guys right now.
That's kind of what you did. We're all coming to. That's exactly what I thought about just coming down, just around there. See if it's
No, I haven't.
Hey, how you doing?
Wow, I got like sound mix on this
How are you? Very good reading. Sorry.
Like fine.
Their products
fever, but really, if nothing pops up for fever, you should probably Mark said, so they started her on they want they said no anticoagulation. And then they said I wrote it in my head. I think there was maybe one other thing. Oh, then they got a urinalysis.
cards ordered.
So you're not feeling great.
Did you know which one it was?
CME.
Around the clicker here. Right. We have started recording our grand rounds on projection. We're recording grand rounds for broadcast to our outside providers. Okay.
All right. Third turn done?
Yes.
This second?
Yes, it is. I did it.
No.
No, he was just talking. He doesn't want to be in the place.
Good morning, everybody. So, Dr. Kulimas, I've been here in Colorado since 2004, and let me see. I did my fellowship at the Cleveland Clinic and fellowship in technology at the University of Kentucky. Worked here at the University of Colorado for a few years, and I have been in private practice for the last 13 years. And I still have the pleasure of giving some talks from time to time, and maybe occasionally see some of your patients as well. So welcome you all, and thank you for waking up early in the morning. I'm going to try to finish a little bit early, even though I'm late, and take some questions. So there's a residency program here, right? Who are residents? All right, start preparing your questions. You shall be kept. We're going to talk about management of cirrhosis, and within the management of cirrhosis, mostly about hepatic encephalopathy. That's the. This is a CME program, and I think I'm supposed to read this, so I'll read it. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the NCCME through the joint providership of the Annenberg Center for Health Sciences, Eisenhower, and the Chronic Liver Disease Foundation. The Annenberg Center for Health Sciences at Eisenhower is accredited by the NCCME, which provides CME for physicians. So you can get a 1.5 AMA CRA Category 1 credits, and there will be multiple email interactions about this. You'll have to provide your social security number, best bank account, and the name of the person. There's also CME for nurses, same 1.5, and there is the same for pharmacists, if there's pharmacists here. So for them, they're called CEUs. And the sponsor is for the program that gave the educational grant to do all this. There's actually several. One is AbbVie, one is Bristol Myers Squibb, the other one is Syndax. So the ideas for today are to recognize the signs and complications due to cirrhosis and the importance of early intervention, describe evolving patient management strategies for hepatic encephalopathy in the hospital and in the outpatient setting. And that transition from that word to that word is probably the most important challenge that we have. And to apply the latest patient management strategies in order to reduce hospital readmissions due to hepatic encephalopathy. So, does anybody know how many people with cirrhosis there are out there? The standard question is, yeah, there's a lot. I see them in the hospital every day, and they come back and they're sick, and they're difficult to look after. And so the official number is there's a lot. We don't know. Why don't we know? Because I could have cirrhosis and I could look fairly normal like I do. There's clearly some things that I don't look normal about. The point is you can have liver cirrhosis and feel healthy and look healthy and have near normal or even normal blood tests. And, diagnosing cirrhosis early is important because we can put in motion multiple things to look after these patients. So when people have a risk factor for liver disease, we should look a little bit further. It is difficult to do that when they come in for flu or when they come in for exacerbation of COPD or CHF or whatever it is, or cellulitis. But if you see a low platelet count or a low albumin, or they have risk factors for Hep C or NASH or whatever it is, maybe doing something to look at that. We can talk about that. So maybe up to 1% of the population, 3 million people, may have histological cirrhosis. Histological means that we do a liver biopsy to diagnose cirrhosis. Well, we certainly try not to do that anymore. Why? Because there's better methods of assessing liver fibrosis. And elastography, either by MRI or by FibroScan or some sort of non-invasive test. There's some blood tests that are not very good, but they're helpful. And the liver biopsy in and of itself is not that great. Sometimes about 30% of patients we will miss the diagnosis of cirrhosis because the needle just goes to an area that looks a little bit better. And so diagnosing cirrhosis may be difficult. So patients at the beginning may be asymptomatic. So thrombocytopenia is probably the most useful thing to look at. If patients have a platelet count less than 150,000, think about it. You could potentially have liver cirrhosis. If you do, let's say, a CT scan or an ultrasound, let's say the patient came to the emergency room. They actually came to visit somebody that was in the emergency room. They get a CT scan anyhow, right? So let's say that somebody did a CT scan. If the CT scan shows a lobular contour to the liver, and then that patient has liver cirrhosis until proven otherwise. But if the CT is normal, that doesn't rule out cirrhosis. So if it's positive, it's in. But if it's negative, it's not out. Muscle wasting, mostly in the temporal areas. When the AST is greater than the ALT, I would say without alcohol consumption and without pregnancy. So what are the 3 things that cause, 3 liver things that cause an AST greater than an ALT? Number 1 is liver cirrhosis. Number 2 is alcoholic liver disease, or current alcohol use. And number 3, and probably the easiest to rule out, is fatty liver in the 3rd trimester of pregnancy. And that's it. Okay? Yes, you could have hemolysis. giving you an AST greater than ALT. Or muscle damage, rhabdo, for example, giving you an AST greater than ALT, because there's a lot of AST in muscles and in RBCs, but those things are sort of self-evident, if you will. So if you see somebody with low platelets and an inverted ALT-AST ratio, that patient should be worked up for liver disease. And as I said, people could potentially have normal liver tests. The etiology may not be current. It could be that this patient had hepatitis C and got cured, but carried it for 40 years, and still sort of carries that stigma and doesn't want to share with you that they had Hep C, but they got cured. It could be that somebody decided to go to college for 20 years, which some kids do. And what is it that you stay in college for? It's not for the knowledge, it's for the parties. So they were partying for 20 years and drinking too much. And well, no, they actually are not. But they may be carrying cirrhosis from drinking, and they quit 3 years ago, 5 years ago, and they still have cirrhosis. Non-alcoholic fatty liver disease, which is what you're going to see the most of, is quite common. And once you develop liver cirrhosis and maybe other comorbidities from the metabolic syndrome, you tend to start losing weight, and you tend to start getting fat out of the liver, because the liver, if it's not healthy, it cannot store fat. Or maybe the patient had some bariatric surgery a few years back, and they lost a bunch of weight, but they already had liver cirrhosis. So think also in the past. And what are the typical decompensations of cirrhosis? Hepatic encephalopathy that we're going to touch on today, ascites, and variceal hemorrhage. But there's multiple other complications that can happen. If you have ascites, it can get infected, and that is spontaneous bacterial peritonitis. Many patients will have little one-way valve defects of the right heavy diaphragm. So every time we take a breath and there's negative pressure in our chest, we're sucking a little bit of fluid into the right pleural space, and that is hepatic hydrothorax. So from today on, when you have a patient that looks like a cirrhotic patient or has a diagnosis of cirrhosis, and they get admitted for a right pleural effusion, send that fluid, not just for the typical things of pleural effusion, but also for the typical things of ascites. So you need to check the albumin in that fluid. It could be the same. And if you have acidic fluid, then you tap both, and you compare the chemistries of both, and that will give you a diagnosis. Okay, that's pretty simple to do. Hepatorenal syndrome, when the portal hypertension is very advanced, then the liver sends X amount of messages through the kidneys, and the kidneys start vasoconstricting the renal arterioles, and that leads to renal dysfunction. And when you have hepatorenal syndrome, usually the outcome is poor. There are treatments for that, and we can help a lot of you with that. The pulmonary complications, portal pulmonary hypertension, and hepatopulmonary syndrome. We seem to have both in Colorado. There's a suggestion that the higher the altitude, the more hepatopulmonary syndrome you have. The patient with portal pulmonary hypertension is the one that comes with right-sided heart failure. The patient with hepatopulmonary syndrome is the patient that comes hypoxic. That tells you that they feel better when they lay down and not when they stand up. So the opposite of congestive heart failure. Hepatocellular carcinoma, of course, that you all see often, and you will see even more often in the decades to come. Portal vein thrombosis, which is a fantastic topic in and of itself, but it happens in a significant number of patients with significant portal hypertension. As the liver gets stiffer and stiffer, the blood has more difficulty moving in, and one day the flow is so stagnant that the blood just clots. And liver cirrhotics, even though they have low platelets and prolonged INRs, they are not anticoagulant. So liver cirrhosis is actually a condition where you have both an increased risk of bleeding and an increased risk of clotting. So both happen. And the corollary of that is how bad the platelets and the INR or PTT are as far as tests to assess likelihood of a patient having clotting disorder. Okay, so liver cirrhosis, patients will have more DVTs than the standard population, more portal vein thrombosis than the standard population. Cardiac disease is common, sarcopenia and osteoporosis are also really common. So today we're going to talk on hepatic encephalopathy, its economic and social burden, hospital readmissions and how to hopefully prevent that, and cognitive impairment. So when you have hepatic encephalopathy, patient comes in, they're totally confused, they have a diagnosis of chronic liver disease, they have flattening tremor, hysteresis. You check an ammonia level, which you potentially could manage the whole case without checking the ammonia, because it really doesn't correlate with the CNS dysfunction. And a normal ammonia doesn't mean that you're functioning well. An elevated ammonia doesn't mean that you have hepatic encephalopathy. So we want to provide supportive care. These patients can come with infections, they can come with medication misuse, they can come with electrolyte abnormalities, all sorts of things. So we want to see what caused the hepatic encephalopathy. And as I said, the most common things are infections, GI bleeding, dehydration, electrolyte abnormalities, or misuse of medications. We are all very aware of the opioid crisis, right? When you have a patient that has liver cirrhosis, the metabolism of opioids is depressed. And so the half-life is prolonged. And it can be prolonged by days. Okay? So you have that patient that just got to the clinic, got a refill for their narcotics, is happy, they're popping them every 4 hours, and all of a sudden they go to sleep. And they will stay asleep for a while. Okay? So that patient you have to watch. What is one of the simplest things that you can do for these patients? Elevate the head of the bed, because they tend to aspirate. Okay? What are the common infections in liver cirrhosis? The three most common infections: UTIs, pneumonias, and SBP. Can you have SBP and no symptoms whatsoever? Yes. Okay, so this thing of, you know what, it's 3 in the morning, I haven't slept, I have a full day tomorrow, patient doesn't have pain or fever, I'm not going to tap the ascites, that's not good medicine. If they have ascites, it needs to be sampled. Okay? But they have low platelets and they have a prolonged INR. What is the risk of causing hemoperidia? 1%. If I correct the platelets, oh, it improves, 1%. And if I give them FFP, way better, 1%. Okay? The risk is 1% no matter what you do. We tend to correct the INR, and we tend to want platelets greater than 50,000, but there's no proof, there's no data that says that that makes any difference. If the patient got discharged from the hospital yesterday for their last hepatic encephalopathy, went home, looked at the TV, and there's this special going on at Burger King for 2 burgers for $6. Or they go and say, I have to have some steak, you know, and they eat too much protein. Typical patients say, I'm losing too much weight, let me, you know, take some protein supplements. That can be an issue. If you gave them diuretics and lactulose, and they got a little bit of a bug, and they're having a lot of diarrhea, and they're peeing a lot, they can have electrolyte abnormalities. Hypokalemia is the most common one associated with hepatic encephalopathy. And then you want to institute long-term therapy. So you want to control all these potential issues, and you want to coach the patient on trying to prevent recurrence of hepatic encephalopathy. And lastly, this is a decompensating event. So that patient should have a consideration for liver transplantation. Okay? By and large, I tend to say that everybody should be considered for liver transplantation. They're not necessarily candidates. They will not necessarily end up on a list. They won't necessarily get transplanted, but it's part of the treatment algorithm, and the thought should be put to that, and the patient, you know, if at all possible, should have at least an elevation. So what are the medications that we use for hepatic encephalopathy? we use lactulose. Lactulose is the mainstay of treatment, and it's a poorly absorbed disaccharide. We'll talk about that. So it's a sugar that doesn't get absorbed. I'll come back to that. And it decreases the blood ammonia concentration, which makes us feel better, but it actually does improve the hepatic encephalopathy. And in time, it may resolve it, and then it may prevent rifaximin, which is the oral medication. It's a non-absorbable oral antibiotic, and it has been shown to reduce the risk of overt hepatic encephalopathy, and it also reduces hospital stay, and it potentially allows you for lesser doses of lactulose to be effective. So we'll talk a little bit about that. When I was in your seat, neomycin was a drug to be combined with lactulose because neomycin is a broad-spectrum, non-absorbable antibiotic. Unfortunately, when you have portal hypertension, you have difficulty for the blood from the gut getting through the portal vein. So there's edema of the gut. And that basically spreads the tight junctions in between enterocytes. And so more things than what you want get absorbed through there or get transported through there into the portal circulation. And that is true for bacteria. That's how we get SBP. And pneumonia, UTI, is colonization from gut bacteria through the portal system that then bypasses the reticular endothelial system of the liver through the collaterals like the esophageal varices that these patients get. And then they see systemically. You get cytotoxins, which trigger the encephalopathy to begin with and trigger further inflammation in the liver. So the gut is actually very important. And maybe 2 or 3 side notes about the abdominal or the gut complications. When you have edema in the stomach, what happens? You get gastroparesis. You lay empty. So the cirrhotic patient says, I get bloated, and I will have nausea and vomiting if I eat a lot. And in the small bowel, you get decreased transit. And if there's decreased transit through the small bowel, that is good for bacteria because they have more time to date and mate. Okay, so you have small bowel bacterial overgrowth, and that gives you further bloating and further diarrhea. And in the colon, the wall is very venomous, doesn't move very well, so your colonic motility is decreased, and that causes constipation. And the constipation again allows for greater absorption of things that you don't want absorbed, and it also allows for hepatic encephalopathy. If you put that constipation with a little bit of narcotics, your typical cirrhotic patient with portal hypertension will get worse constipation. The other side, remember that CT scan that the visitor got when they got to the emergency room? A good cirrhotic will go through the emergency room, they'll get a CT scan, and the radiologist will read right colonic wall edema, rule out colitis, right? Which is good for us, the gastroenterologists, because then we do another unnecessary colonoscopy. Okay? But the patient never had colitis. What they have is right-sided colonic edema from portal hypertension. Okay? And that has a name. It's called portal hypertensive colonopathy. Okay? In the rectum, you're going to see varices. They're going to have large hemorrhoids, a little bit of hemorrhoidal bleed. And on the right side, they're going to have more edema than on the left side. For whatever reason, the SMV, the superior mesenteric vein, suffers more than the inferior mesenteric vein in their drainage. So neomycin then gets absorbed because of all of this, and it goes to the kidneys, and it makes them fail, and it goes to the auditory system and gives you deafness. I did have one patient that had renal toxicity, and 2 that had ototoxicity from neomycin, and I was done. I never used it again. Flagyl, which is not approved, and vancomycin, which is not approved. Vancomycin being somewhat expensive and a drug that we may want to save for others. But I would say flagyl, and to a certain degree, quinolones have been used to decrease the bacterial load of the gut. And when they do that, they help in the management of hepatic encephalopathy. That is if you cannot get rifaximin. So the patient that cannot afford the rifaximin or does not get the rifaximin for whatever reason, Flagyl is an option. And of course, Flagyl has side effects of their own. Palate taste and nausea and vomiting being probably the most common one. And the quinolones have side effects of their own. Tendinitis and the bacterial resistance, probably the most common ones. So lactulose, as I said, the majority of patients will improve with lactulose. What happens to lactulose is it's a non-absorbable sugar, and this one gets fermented in the colon. And fermentation, other than giving us beer, it gives us a lower pH. And so when you form lactic acid, you lower the colon pH. That decreases bacterial reproduction because the bacteria have a sweet spot for reproduction in the pH category. And it also decreases ammonia absorption because lower pH favors the production of ammonium rather than ammonia. And the ammonium, which is NH4 does not get absorbed. Okay, so the NH3, the ammonia does. And then the cathartic effect, which is an osmotic diarrhea, increases the protein excretion, the nitrogen excretion, and it decreases bacterial overload by increasing the transit in the gut. So multiple mechanisms by which lactulose actually does its work. So what's the correct dose of lactulose? There is no correct dose of lactulose. The correct dose of lactulose is you give enough for the patient to start stooling, and then you give enough to get to a sweet spot. And the sweet spot is usually 2 to 4 bowel movements a day. Okay? So you start strong. You can start giving it every 2 hours when the patient comes in. And then when they start having diarrhea, you back off. That actually needs for you to come back and to talk to your nurses on a fairly regular basis. So the order of lactulose 30 cc's BID, and I move on to the next basketball game, that is not what is best for the patient. So you can give it through EMG tubes, or, and this is a double-edged sword, let's say that the patient cannot take it orally for whatever reason, they have small bowel obstruction, you can give it as a retention enema. How many of you have given it as a retention enema? So, okay. So the good thing is that it works. The bad thing is that the nurses are not on it. Okay? It's going to cause a mess. But it's what's best for the patient. Okay? And then bring something sweet for the nurse. Typical side effects for lactulose: abdominal distension with the patient, which the patient already has, cramping and diarrhea because it's causing increased motility in the gut, and it causes diarrhea. So the patient comes back and says, "No, doc, I'm not taking the medication because it gives me diarrhea." And you're like, "That's why I gave it to you. You have to have diarrhea." So the point here is tell the patient what to expect. Don't just send them out with the medication and say, "Take this twice a day." Well, this is going to give you this, but the importance of taking this such. And if the patient is knowledgeable, they're much more likely to tolerate the side effects. If you give too much lactulose, the patient will get dehydrated and will have hypokalemia. And you know what's going to happen? They're going to have hepatic encephalopathy from that. So lactulose has a sweet spot. Rifaximin, minimally absorbed oral antibiotic, broad spectrum. It kills both aerobic and anaerobic enteric flora. There's no clinical drug interactions that are reported. There's no dosing adjustment required in patients with renal or liver disease, and it's currently approved for the treatment and prevention of hepatic encephalopathy. And this is the study. If you want to go back to it, is by Nathan Bass in the New England Journal of Medicine in 2010. And this was a study of basically patients that had stage 2 con classification hepatic encephalopathy, and they obviously had cirrhosis. And what the study looked at was the proportion of patients without breakthrough HE. So the patient had a diagnosis of HE, and they were enrolled in the study. And then what we looked at is when the patient developed another episode of panic encephalopathy. And it initially went where I think it was 2 years or 6 months, something like that. 2 years, and then there was a long-term open label arm. Now, 91% of the patients in both arms were also on lactulose. 9% were not on lactulose because of intolerance or some other issues. But 91% of the patients were on lactulose. So the treatment should read rifaximin plus lactulose versus lactulose alone, right? And as far as the breakthrough, there were the prevention of breakthrough. Rifaximin had greater prevention than placebo, and that was statistically significant. That was one of the endpoints of the study. The other endpoint was prevention of readmissions, and lactulose prevented more readmissions. Sorry, rifaximin prevented more readmissions than lactulose. So based on those two findings, which were both statistically significant, the drug got FDA approval. So economics and social burden. If you are a hospital, what do you want? You want a lot of patients coming in. You want a lot of patients admitted and all your beds filled up. And you want to get rid of them really fast to get a new patient in. I think because the charges of the first day of the admission are greater than the charges of having the patient put in their PO box here. Okay? So you want them in, you want them out. And so you get a lot of pressure to discharge. And discharge early in the morning, first thing we do, don't forget about that. And so we are seeing more and more liver disease and more admissions for cirrhosis. Why? Because we have this epidemic of chronic hepatitis C that affected about 5 million people in the United States. And now we have an epidemic of non-alcoholic fatty liver disease. And again, going back to the metabolic syndrome, we think there's about 100 million people that are obese in the United States, and they have non-alcoholic fatty liver disease. That's a lot of people. And of them, somewhere between 15 and 25%, so let's say between 15 and 25 million, will have non-alcoholic steatohepatitis, so inflammation of that fat in the liver. And over a period of decades, the same way as it was with hepatitis C, that will lead to advanced liver disease and cirrhosis. And these patients will have problems with 3 organs in particular. They'll die of heart disease, oncology, cancer, or liver disease being the third cause. And how do people die of liver disease? Complications of cirrhosis or hepatocellular carcinoma. So you're going to see more and more and more of this. There's a lot of Hispanics in Colorado. Okay, it's our first minority as far as patients go, and more so in the south side of the state than in the north side of the state. And Hispanics genetically are more predisposed to developing NASH. So you're going to see a lot of Hispanic patients with these. I would say, again, for NASH, if you have somebody that is that has features of the metabolic syndrome and has somewhat elevated liver tests, and it's not necessarily that they should have elevated liver tests, but let's say they have elevated liver tests and they come to see you for hypertension or management of diabetes, you should think about, do they have liver disease or not? Okay? And so we're going to see more and more and more admissions for liver cirrhosis. And if we have more admissions for liver cirrhosis and we do more things to these patients, the charge will increase. Very interesting. The cost does not increase as much as the charge. But that's something to ponder when we want to choose between hospital administration and practicing medicine. I'll leave it at that. We can talk about politics later. So let's go back to rifaximin and lactulose. And this is frequency and duration of hospitalizations. And when patients were given just lactulose versus when patients started receiving both lactulose and rifaximin. So the mean number of hospitalizations statistically significantly decreased, and the mean days for hospitalization also decreased. So rifaximin makes hospital administration happy. No, sorry, it makes patients better. Okay, and so it prevents readmissions and it shortens hospital stay. What happens when you stay in the hospital too long? You hurt the patient. And this is true. You don't want patients to be in the hospital too long. Somebody's going to come out and order some tests, get gung ho about something. We're going to do something that we're not supposed to do. Get the patient in, take care of them, and get them out. All right. Total time hospitalized and charges during the lactulose versus lactulose and rifaximin. I showed you that already, and then the hospital charges are significantly decreased. If you were able to convince the insurance plan that by decreasing the inpatient charges, they should sort of credit the patient for outpatient cost of the rifaximin, that would be nice, but that is the second part of our political conversation, actually, after the talk is done. And then what happens to the family of that patient? Because hepatic encephalopathy is bad enough for the patient, but it's pretty terrible for the family. So let's say that you have somebody with overt hepatic encephalopathy. Let's say they spent several days in the hospital, they were confused, they even maybe spent a couple of days in the ICU, and the patient finally gets better. You say, go back to the garage, pick up your car, and go home. You can't. You shouldn't. Okay, these patients get into traffic accidents, and they will drive near the school where your kids go. Okay? And it has been shown and documented that these patients should not drive until they or operate heavy machinery until they're proven to be back to a certain level of functioning. So first thing that should happen is you say, you know what, you have a diagnosis of overt hepatic encephalopathy. You're not allowed to go. Okay, so somebody needs to pick you up. Somebody needs to take you to your appointment. Somebody needs to take care of you. If you're confused, how do you know when you took the last medication? Do you know if you took it right? Did you know to mark it down? Do you know if you picked up the medication from the pill box and left it somewhere else? What is the typical thing that hepatic encephalopathy patients tell you? I go to the other room to do something, by the time I get to the next room, I forget what I was doing. Okay? And maybe you'll find the medication there. So somebody needs to give them the medication. So the families taking care of these patients, they have a significant economic burden. They stop saving, or they go into debt, or they stop going to school, or they're late on their bills, or they don't buy as much food as they would want to, or they move to a cheaper, more affordable place, or right out they go into bankruptcy or get evicted. So the cost to the family unit is significant when this medication happens, when this complication happens. And there's something called the caregiver burden inventory, and this is all cirrhotic patients. When the cirrhotic patient is unimpaired, you still have some cost. The patient needs to come to the hospital, needs to be taken care of, et cetera, et cetera. When they have minimal hepatic encephalopathy, which is very difficult to diagnose, the patient has a little bit of dysfunction, but not quite overt confusion, the cost will increase because they'll stop doing certain things. And then when they have overt hepatic encephalopathy, the cost really skyrockets for both the patient and the family. Typically, obviously, if the patient is not thinking right, chances are they're not going to go back to work. All right. And this is looking at patients with the costs of the patients when they're hospitalized and when they are not hospitalized. And this is costs that are decreased by the use of the right medications in managing the hepatic encephalopathy. So if you manage this disease appropriately, patients will save. Hospital readmissions. So hospital readmissions are common. You have certain patients that you get to know very, very well through your tenure. And this is a retrospective study from a transplant center looking at 402 patients. And these patients, once they get admitted, they are followed and censored of death and elective admissions such as transplant or post-procedure observation or the day of the last clinic. The median follow-up was about 2/3 of a year. And they included patients hospitalized for ascites, SVP, renal failure, hepatitis, or variceal hemorrhage. Median time to readmission was 67 days, and the median number of readmissions was 2 up to 40. Overall rate was 2 hospitalizations per person a year. And so you see that within a week, about 15% of the patients will come back. Within a month, maybe up to 40%, and overall, there's I think it's 67% of the patients will have readmissions. So these patients will come back, and it's outpatient management that will prevent that. What are the causes for readmissions? AG is the orange, and the blue is all cause. Please note that the collars are Broncos collars, and so this talk is made specifically for Colorado. So within 30 days, the majority of readmissions are for hepatic encephalopathy. And that is true at 6 months and at 1 year. So hepatic encephalopathy, a significant cause for readmission to the hospital. I don't like this slide too much because it's a univariate and not multivariate analysis of admissions and hospital length of stay before and during rifaximin. But basically, the columns to look at are before or during rifaximin, and at 3 to 6 or 12 months for all annualized data, the use of rifaximin decreases the hospital admissions and it decreases the length of stay, and that is statistically significant. So it is a good intervention for the patients. And this is a look at a hospital where patients, they looked at patients from the time that they started using rifaximin on a regular basis to, and compared it to the time before they used rifaximin. And from the time that they used rifaximin, hospital length of stay decreased, and the mean length of emergency admissions was decreased significantly. So again, the same thing. The problem is that you discharge the patient. In the hospital, things are easy. The patient is lying there. Nurse comes in, says, take this medication. The patient takes the medication. It's all good. We'll bill you later. That's a different problem. When they get discharged, they go to the pharmacy and they are like, okay, give me the prescriptions. Well, now that costs too much. I'm not going to take it. That costs too much. I'm not going to take it. That one is cheaper. I'm going to take that one. And problems occur. So you need to, again, have an idea. And this is not necessarily for the resident to manage, but it should be a team, including the pharmacist and other people to manage. But the patient should know what they can or cannot afford, or what they will be able to get or not when they get discharged from the hospital. Let's say that I give a combination of drugs. Let's say I give them furosemide and spironolactone, which work better together for the management of fluid retention, and potassium wasting of furosemide is counterbalanced by the potassium sparing of spironolactone. But then I go to the pharmacy and I cannot pick up one of the two. Let's say I don't pick up the furosemide, and 4 or 5 days later I have a potassium of 7, which is not a GI or liver problem, so I don't know much about, but they tell me it's bad for the heart. Okay, things like that, simple things. The issue with rifaximin is that it tends to have an initial difficulty in getting it, and for many insurance plans, the patient has either high copay or a high overall cost. And so it would be incredibly important to sort of assure that those patients will have access to the rifaximin when they're getting discharged from the hospital. That can be planned in the hospital so that there's no breakdown in the continuity of that care. That will prevent the hepatic encephalopathy from coming back, patient from getting readmitted. to the hospital. And that is pretty common, okay? Sometimes we discharge the patient without the right medications, and that is the problem of the doctor. Not giving the right medications to begin with, that is a problem. All right, so I think we made this one, that rehospitalization rates due to recurrent injury can probably be prevented. And it takes all of those things that I was touching on. The patient needs to understand not to go home and restart the whey protein, or not to go to Burger King on discharge, or God forbid the bar next to Burger King, or they are not to abuse their diuretics. I had a patient that loved that she had nice legs, you know, and when she developed edema, you know, that was the number one thing that bothered her because she couldn't use her high heels. And she would go home and get herself into renal insufficiency from using diuretics because she wanted to see her ankles. So, you know, each patient is driven by something different. And you need to hopefully learn about that so that you can help them best. All right, and then lastly, cognitive impairment. So your patient came in, they were really acting goofy, and clearly they weren't able to do math, they weren't able to drive, they weren't able to function. That's why they came to the hospital. And now you give them some lactulose, and you give them some rifaximin, and you treat it, whatever you have to treat, and they're looking good. And you're going to send them home, right? And do they go back to baseline? That's what your discharge note says. Patient back to baseline, okay for discharge home, right? So this is the, I love these. One of these days we're going to use them. So this is resting state functional MRI imaging. And these are healthy controls, panel A. Panel B is the cirrhotic patient without any history of hepatic encephalopathy. Panel C is the patient with cirrhosis and current minimal hepatic encephalopathy, which is usually diagnosed by psychometric testing, which is, again, expensive and difficult to do. We only do it in studies. And lastly is the cirrhotic patient with previous overt hepatic encephalopathy. And it's not your eyes. This is brighter, and this is the dimmest of all the images. The brain is just working at a decreased capacity. The neurons are not turned on. The light is off. Okay, so the patient may sound and look better, but they tend not to go back to their baseline. This is an inhibitory control test. This is a test that has two parts, and the patients are supposed to learn how to punch different things or point at different things in the computer. You can do it on your phone. And the first half, you sort of learn, and the second half, you're sort of supposed to make less errors while you're doing the test. So these are normal patients. This is people that have had minimal hepatic encephalopathy, and there's a good learning curve. There's less errors. There's a good learning curve for both. For the cirrhotic patient with overt hepatic encephalopathy, after it resolved, their learning curve is blunted. Okay, so they don't learn as much by this method either. And these are other ways of looking at things, cognitive functions before and after liver transplantation. So, got the patient listed for liver transplant. Now Denver has 3 liver transplant programs. Not that we needed 3, but we have 3. So you got it into one of them. They did a great job. The patient has a nice new liver. It's working well. And you're like, okay, go back, work, and pay taxes just like I do and help me out. And so what happens? This is liver transplant patients in blue that did not have previous overt hepatic encephalopathy. This is patients in red that had episodes of hepatic encephalopathy in the past. And in the attention before and after liver transplantation, while the recovery of the hepatic encephalopathy patients is greater, they end up at a place where they're still at a disadvantage compared with patients that received liver transplantations that never had hepatic encephalopathy. Same for memory and same for executive function. Okay? That's like you guys after call or something like that. All right. This is a little bit more granular description, but basically you're going to see that there is problems in all sorts of these areas: immediate memory, visual, spatial, language, attention, delayed memory, and total scores. These are patients, again, that have hepatic encephalopathy before liver transplantation. This is opposite now in blue. So previous HE and no previous HE in the orange. So the orange, they tend to perform better than the patients who had previous hepatic encephalopathy. So for that patient that came back 40 times in 1 year for recurrent hepatic encephalopathy, he's not going to work that well after liver transplantation. He's not going to be all that capable after liver transplantation. So preventing the recurrence of hepatic encephalopathy today will hopefully allow for that patient to have better functioning in days to come. So, in conclusion, hepatic encephalopathy is an economic and social burden. Increased burden is realized not only by patients, but also by their caregivers. And it is an important cause of hospital readmission, and one that you're going to see more and more and more and more. And it is not a completely benign complication. In other words, it has long-term sequelae, and it is worthwhile trying to prevent it. It may affect future learning that may persist even after liver transplantation. So I think there's a couple. We'll be sent a 45-day. That's the part of the Social Security number. And then you can go to this website. There's multiple other lectures that are available for free electronically to you guys in liver disease through this website. With that, I think we have 5 minutes that if you have any questions, I would be happy to answer. And thanks for the invitation. Yes.
How often or how soon do you usually start rifaximin? I know our patients a lot of times they'll come in, they'll only be on lactulose, and then we're told it's when they fail it or when it's not seeming to work well enough. But a lot of that could argue that maybe just start right away.
Yes. So the label indication is to give it after the first episode of hepatic encephalopathy for prevention of future episodes. Having said that, most of us use it from the get-go. And some of us even use it before the first episode for those patients with minimal hepatic encephalopathy. Minimal hepatic encephalopathy just means that you're on your way to having an episode of hepatic encephalopathy. So we tend to start the hepatic encephalopathy as soon as the patient can take oral medications when they get admitted to the hospital. And our hospital and our pharmacy does not have a problem with that. We don't seem to have an access problem with that. You might have different circumstances here, but if you don't, what rifaximin also allows you to do is not just resolve the episode faster and get the patient home faster, but it also allows you to use less lactulose. And there's not a whole lot of data here, but basically, if with lactulose alone you want 3 or 4 bowel movements, maybe with lactulose and rifaximin you're okay with 2 or 3 bowel movements. And less lactulose means less distension, less gas, less diarrhea, more patient compliance. So the patient may actually be more compliant with the lactulose and they have to take it just once a day as opposed to twice a day. So we tend to use it whenever possible for all the patients that have hepatic encephalopathy.
For a question about variant that they don't have hepatic encephalopathy, very obvious cirrhosis with ascites, is lactulose enough? What's the outcome?
I cannot quote you a paper that would have addressed that. Most of these medications get given when the patient develops hepatic encephalopathy. Many times we will use if the patient can get it, and again, it's a matter of what the label says what the insurance plan allows, et cetera, et cetera. And oftentimes I have patients that, your only manifestation is a disturbance in the sleep pattern. And for cirrhotic patients, the typical thing of the cirrhotic patient is they tell you, at night I cannot fall asleep, and in the morning I cannot get up. So their sleep-wake cycle gets disturbed, and they fall asleep in the early hours of the morning, and they sleep into the day. And I'll use it for that, as well as, you know what, I just know that I'm not functioning as well as I usually do. That minimal hepatic encephalopathy kind of thing. I may use it for that. But I can't say that that there's a lot of easiness in getting the drug approved for that. Which one works better? Lactulose or rifaximin, because it's easier to use and better tolerated. We tend to start with rifaximin when you can't use it with lactulose. There's not a whole lot of literature that will defend that point of view. One more minute, one more question. Yes.
Clarification, Gomez, when I was in residency, we'll start out that gathering between government and active, you know, reality is that everybody need to be on. Are they better off on Aldactone and Lasix in all patients, or can some just do well enough with one or the other?
So, the patients have sort of enough decompensation of the hepatorenal axis that they start retaining fluid. The best combination, the most effective therapy is the combination of Lasix and Aldactone. And usually the starting dose is 100 milligrams of Aldactone and 40 milligrams of Lasix. If that doesn't work, you go to double that. If that doesn't work, you go to 300 and 120. And if that doesn't work, the maximum dose is 400 of Aldactone and 160 of Lasix. And then after that, you get a patient refractory. Of course, the number one intervention is for the patient that has salt. If they have salt, the diuretics are not going to work very well. Does Lasix alone or Aldactone alone work for some patients? Yes, but you sort of should start both when they have fluid retention, and then you can back off. And what I tend to do is from 150 back off to 50 and 25, which is not the starting dose, but it may be an exiting dose, if you may. And then I tend to just stop and tell them to take both on an as-needed basis, maybe 3 days a week, maybe 2 days a week. So I tend to keep that combination as opposed to giving them one drug by itself. The combination works better with each one of those medications alone. One last question. And parking meter doesn't expire for 1 month. Thank you, guys.
Thank you.